Troponin T case studies. Why using the only Troponin T test on the market matters. The case studies that follow illustrate how using the Troponin T test from Roche Diagnostics will assist you and your clinical staff to properly manage patients showing signs and/or symptoms of acute myocardial infarction, or AMI. The subjects range from 33 to 73 years old. All subjects presented with signs and symptoms of acute coronary syndrome. Each subject had Troponin T tested at least twice, with 0.01 nanograms per milliliter being used as the 99th percent cutoff. 4 patients had renal disease, and 4 out of the 5 subjects were diagnosed with an acute myocardial infarction. In each case, the use of the Troponin T assay was critical in aiding in the diagnosis. Case study number 1. A 33-year-old male presents with complaints of tightness and discomfort in the left chest area over the last 24 hours. The patient denies having had shortness of breath or nausea. Vital signs were normal. The patient's medical history and physical exam are unremarkable, denying any history of cardiovascular disease, diabetes, or smoking. The EKG shows sinus tachycardia. The blood results for the comprehensive metabolic panel, CBC, and coagulation tests are normal. The Troponin T at baseline is 0.13 nanograms per milliliter, which is elevated greater than the 99th percentile. At 6 hours, the Troponin T has significantly risen to 0.6 nanograms per milliliter, and at 12 hours, the Troponin T continues to rise to 1.3 nanograms per milliliter, signifying an acute change. The patient is diagnosed as having a non-ST elevated acute myocardial infarction, and this is confirmed by the universal definition of MI. The patient has at least one Troponin T concentration greater than the 99th percentile cutoff value of 0.01 nanograms per milliliter within 24 hours, which signifies cellular necrosis. There is also a rise in the Troponin T concentrations, which signifies an acute change. And the patient complains of chest tightness and discomfort, which signifies ischemia. The coronary angiogram demonstrated mild irregularities with no significant coronary artery disease and notes the infarct-related artery in the obtuse marginal branch with no residual obstruction. In conclusion, all 3 criteria for an acute myocardial infarction are satisfied, which include an elevated Troponin T concentration greater than the 99th percentile, a rise in the Troponin T concentration, and clinical presentation with symptoms of ischemia. Case study number 2. A 58-year-old male presents with substernal chest pain with radiation to the left side of his jaw. The onset of pain was 4 hours prior to the arrival in the emergency department. The patient does not gain relief from nitroglycerin and denies pain prior to this episode. The chest X-ray shows bilateral infiltrates. The patient has a history of hypertension, hypercholesterolemia, COPD, renal insufficiency, and a history of smoking for 20 years. The EKG identifies an anterolateral myocardial infarction. The CBC and KIM panel are normal with the exception of creatinine level, which is 1.4 milligrams per deciliter. This concentration calculates to a GFR of 52 milliliters per minute, signifying mild renal insufficiency. The NT-proBNP is 113 picograms per milliliter, which is considered normal. NT-proBNP levels in patients younger than 75 years old should be less than 125 picograms per milliliter according to the manufacturer's expected values. Therefore, in this case, the NT-proBNP is negative. The Troponin T at baseline is 0.12 nanograms per milliliter, which is elevated and greater than the 99th percentile. At 6 hours, the Troponin T rises to 0.23 nanograms per milliliter. At 12 hours, the Troponin T continues to rise and is 0.25 nanograms per milliliter. At 24 hours, the Troponin T is 0.23 nanograms per milliliter, and at 48 hours, the Troponin T is falling down to 0.17 nanograms per milliliter. The diagnosis is a non-ST elevated acute myocardial infarction. This is confirmed by the universal definition of MI, where the patient has at least one Troponin T concentration greater than the 99th percentile of 0.01 nanograms per milliliter in 24 hours, which signifies necrosis. There is a rise and fall with the Troponin T concentrations, which signifies an acute change. The patient had complaints of chest pain and had EKG changes, which signifies ischemia. The coronary angiogram showed a partial occlusion in the left circumflex artery with an intracoronary thrombus and reduced blood flow. All three criteria for acute myocardial infarction are satisfied with troponin T concentrations greater than the 99th percentile, the rise and fall of troponin T concentrations, and clinical presentation with symptoms of ischemia. Case study number 3. A 51-year-old male presents with pain rating at 6 out of 10, with 10 being the worst. The patient's blood pressure is elevated, 176 over 118, and the heart rate is also elevated, 122 beats per minute. The chest X-ray is normal. The patient has a history of diabetes mellitus for 25 years, hypertension for 15 years, chronic kidney disease for 15 years, and a family history of coronary artery disease. The EKG is normal. The patient's GFR is 7 milliliters per minute, and the creatinine is 7.5 milligrams per deciliter, signifying end-stage renal disease. The patient's NT-proBNP result is 5,375 picograms per milliliter, which is elevated. A normal NT-proBNP is less than 125 picograms per milliliter for someone younger than 75 years old, according to the manufacturer's expected values. Therefore, in this case, the NT-proBNP is positive. The troponin T at baseline is 1.2 nanograms per milliliter, which is greater than the 99th percentile, and at 4 hours the troponin T increases to 1.27 nanograms per milliliter. This patient has chronic kidney disease, and the elevated troponin T concentrations were initially attributed to his renal disease and were perceived as false positives. The physician ordered a troponin I to confirm the perception. The troponin I result was undetectable, and the patient was discharged despite the elevated troponin T concentrations. 8 hours later, the patient presented to the ED with symptoms of chest pain, ST changes on the EKG, and an elevated troponin T concentration of 1.7 nanograms per milliliter. The patient was diagnosed with an anterior wall ST elevated myocardial infarction and was immediately transferred to an alternative hospital for appropriate intervention and follow-up. In conclusion, the fourth-generation troponin T assay is the only troponin test cleared by the FDA for stratification of cardiac risk in patients with chronic renal failure. An elevated troponin T in a patient with renal impairment is a true positive result, which identifies myocardial injury and further cardiovascular risk. The elevated NT-proBNP and troponin T both signify risk. Case study number 4. A 73-year-old male presents with complaints of minimal chest pain. The patient is chronically ill and cachexic. The patient has a history of coronary artery disease, myocardial infarction, and a history of coronary artery bypass graft. The patient has a permanent pacemaker and a history of smoking. The EKG is non-diagnostic due to the ventricular pacemaker. The BUN is 67 milligrams per deciliter. Creatinine is 2.8 milligrams per deciliter. The GFR is 26 milliliters per minute, all signifying severe renal insufficiency. The total CK is 73 units per liter, and CKMB is 5.8 nanograms per milliliter. The troponin T is 0.14 nanograms per milliliter at baseline, which is elevated greater than the 99th percentile. At 24 hours, the troponin T remains at 0.14 nanograms per milliliter. The patient is diagnosed with unstable angina. The patient has chest pain and elevated troponin T levels. However, there is not an acute change or rise in the troponin T levels to support a diagnosis of acute myocardial infarction. Evidence of myocardial injury with necrosis may be detected by troponin in clinical conditions associated with non-ischemic myocardial injury, such as critical illness, renal failure, heart failure, sepsis, myocarditis, arrhythmias, or pulmonary embolism. Chronic elevated levels of troponin T do indicate a greater risk for adverse events in the future. The conclusion is, this patient was not diagnosed with an acute myocardial infarction due to neither a rise or fall in the troponin levels. The elevated troponin T does identify a greater risk, and the patient should be clinically followed. Case study number 5. A 59-year-old female presents with chest pain, nausea, and diaphoresis. She has a history of hypertension and hyperlipidemia. The EKG identifies sinus tachycardia with ST abnormality. The echocardiogram shows a normal left ventricular ejection fraction of 60 to 65%. The GFR is 51 milliliters per minute, which represents moderate kidney insufficiency. The troponin T at baseline is 0.034 nanograms per milliliter, which is greater than the 99th percentile, and at 4 hours increased to 0.087 nanograms per milliliter. The patient is diagnosed with paroxysmal supraventricular tachycardia with acute myocardial infarction. The troponin T elevation in rise signifies myocardial injury with necrosis, which can be associated with dysrhythmias. In conclusion, all three criteria for an acute myocardial infarction are satisfied, which include an elevated troponin T concentration greater than the 99th percentile, a rise in the troponin T concentration, and clinical presentation with symptoms of ischemia. These case studies demonstrated how using the Troponin T test from Roche Diagnostics can assist you and your clinical staff to properly manage patients showing signs and/or symptoms of myocardial infarction.